He waits patiently.
I'm playing with my emails.
On the same screen?
Yeah, I have it kind of minimized to the side. You shouldn't be able to see that piece.
No. No, I don't.
You should be able to see my PowerPoint.
I see looks like axons and dendrites or something like that.
Yep. Yep.
Or neurons,
Yeah. But you should, yep. Well, Hillary disappeared. So who do we have? Wait a couple more minutes before we start, because we only.
Hi, how are you?
Who am I hearing?
Betty.
Hi, Betty. How are you?
I'm good.
Good to have you on board.
Anytime.
Yeah. I see someone who's connected by phone. I don't know who that is. Let's see, who do we have? We have Ellen.
Hi.
Hiya. Hillary, Matt, Betty. There's 7 people so far. Good. We'll get started in just a minute.
Can I ask you guys a question?
Sure.
How does this with NAMA I'm so behind the 8 ball sometimes, but whatever. I have to renew my membership with NAMA as an Ayurvedic practitioner. They have this whole grandfathering clause now? Do you grandfather to be an Ayurvedic doctor?
Well, if you think you qualify under the criteria that they have for an Ayurvedic doctor, you can make an application for that.
Mm-hmm.
I haven't because I don't have the hours or the skill set for the Kalpa Dravagunyas.
Yeah.
So so it would be not appropriate for me. So look at the criteria they have under the Ayurvedic doctor. If you think you fit, then make the application.
Well, I think like you, Dr. Buffo, too, being a nurse practitioner, I have OBGYN and family.
Right.
But here, I've done I've been a massage therapist for 20 years. I've done herbal medicine. I've done yoga therapy. I mean, I'm a yoga teacher, but I still say that you'd have to be clinically trained, right? In India, I would think going to the panchakarmas and, I mean, like the whole bit, you know what I mean?
Yeah, I think if you don't think you qualify, I would just say you don't and just be
No, I'm just gonna, okay.
You know, and so I think that would be,
Alrighty.
because that's what I'm doing, you know, and
Are you doing where are you doing your hours of training?
I'm not doing the qualification. I've decided not to.
Okay, so you're qualified as an MD Ayurvedic practitioner?
Yes. And I'm keeping it there. I'm good.
Yeah, me too. You know, I was thinking the same thing. And with these CEUs, how does it does Karpalo have a training the same as this advanced practice training? Are they planning on having one, or is
We're having 3 weeks next year.
It's a 3-week intensive?
We're having, one is going to be a long weekend, one's going to be a 5-day, and two are going to be long weekends, and one's going to be a 5-day.
Okay, and this is just to for everybody to get more trained as Ayurvedic practitioners.
Yes, to expand our current scope of practice.
Okay,
Right.
all right, got it.
Yeah, we know there's a lot of question around whether or not can it apply to, you know, qualifications for Ayurvedic doctors, and I think we don't know yet. You know, it's just kind of.
Yeah. Well, yeah. Mm-hmm. Okay.
This is a good question, Betty. All right, so why don't we get started? And you guys probably all got Hillary's email with the 4 cases I wanted to go over, which would kind of describe some of the things we talked about last week. You know, some of the anatomy and how the anatomy is applicable to the pathology. And what I'm going to do is I'm going to really focus on the Western view of the pathologies here. And we're going to talk about Alzheimer's disease and dementia, which is a pathology that's, you know, reaching crisis proportions in our culture. It's confusion with Parkinsonism and Parkinson's disease, and those two things are different etiologies and different diseases and should be clearly separated. And then we'll also, you know, briefly talk about some mimics. We're going to talk about stroke and the current workup of stroke and the importance of getting stroke victims to their health center rapidly because of clot-busting medications that we can use on them to save brain tissue. And then we'll close with a talk briefly about sleep disorders. And by that point, hopefully I will not have put you to sleep, because then we'll know a new treatment for insomnia. So we'll start with the first case, which is, they'll be a little bit out of order. We'll start with case 31, which is the Alzheimer's dementia case. And this is a case of a 73-year-old man who is brought in by his wife with concerns about his memory that's getting worse. He's a retired engineer who's been recently getting lost in the neighborhood, which is a very common complaint, you know, disorientation to place. And he's lived there for 30 years. He's been found wandering and often been brought home by neighbors. When asked about this, he becomes upset and defensive and states that he was just trying to get some exercise. So the component of denial is very frequent. He also has trouble dressing himself and balancing his checkbook. So quantitative analysis lacks. And he has a physical examination. And when he was evaluated for his mini mental status examination, which is a standard examination, he scores 12 out of 30 on the mini status exam, which is a test of cognitive function, which indicates he has dementia. So when someone comes in with a possible clinical diagnosis of dementia, Alzheimer's disease is an untreatable, incurable disease. However, there are many Alzheimer's mimics that are treatable and curable. So one of the things we need to consider as we work up our patients who may have had cognitive loss, sensory loss, and disorientation is, do they have something that we can treat? And so frequently a metabolic workup is done, particularly assessing routine electrolytes, sodium, potassium, chloride, and carbon dioxide levels, or bicarbonate. And very frequently an imaging examination is done to see if there's any organic lesions that need treatment, such as hydrocephalus, brain tumors, or stroke, which can mimic dementia. CAT scan is done and it shows atrophy of his brain, which is kind of expected for his age at 73. So he's diagnosed with dementia and likely from Alzheimer's disease. So what is dementia? What is its diagnosis? How do we consider it? Well, the clinical diagnosis of dementia is a loss of intellectual function, which results in a loss of social independence. That's the DSM-4 diagnosis. And Alzheimer's disease increases from age 70 by approximately 1% per year per age. So you can figure if you live to 140, 100% of people will have Alzheimer's disease or some form of dementia. What we want to exclude are the pathologies we can treat, such as infection. And it's not unusual, particularly in female patients, to have an overwhelming bladder infection and present with dementia. And to treat the bladder infection reverses the dementia completely. Alcoholism is a syndrome where depressed patients self-medicate, and querying them as to their behaviors is an important part of the clinical assessment. Medications. Frequently, elder patients are on boatloads of medications. Many of them can change their mental status in unusual ways, particularly drugs for treating hypertension. They can change the blood pressure, it can change the circulatory flow in the brain, and patients can result with cognitive losses. Could they be hypothyroid or hyperthyroid? Both can give you mental status changes. Are they nutritionally sound? Are they lacking protein? Protein-calorie malnutrition can present as Alzheimer's disease and dementia. Have they had a stroke, which you'd see on the CAT scan? Have they had trauma to the brain? One source of dementia that is commonly overlooked is geriatric abuse. And it's probably about 4% of patients who present with dementia are abused elders. And as clinicians, we are mandatory reporters. So if we suspect abuse, it's important to interview the patient alone, absent from the caregiver, because they'll admit that some things have gone awry. So the diagnosis of dementia is usually made based on memory loss, plus, some type of either language, calculation, spatial orientation, decision-making, abstract reasoning, judgment, or performing tasks are lost in conjunction with the memory loss. Alzheimer's disease is nowadays categorized into 7 stages and has approximately 5 to 10 year progression from diagnosis to death. It generally progresses from sensory loss to memory loss to calculation loss to higher function loss to functional loss to basic life processes lost, like heart rate, like respiration. So the 7 stages progress finally to respiratory and cardiac loss of function. Physiologically and pathologically, what we see in the brain is the development of inflammation around the neurons in the areas of the microglia, and what looks like tangles and plaque development in the brain. And on the first slide, you can see here, these are normal neurons. And what's happening at the ends of the neurons is we have the dendrites are disintegrating. And as a result, they're developing plaques around these dendrites, which are long ends of the axons, and they come out. And there are deposition of certain proteins in them. The most common protein we see in them is amyloid. And we can, the next slide is not going. Okay, there we go. Oop. Here's a photomicrograph showing this plaque, surrounding the neuron and these neurofibrillary tangles. You can see kind of swirls of this kind of protein deposition. If we stain these for amyloid, that protein, you can see that there's a significant amount of amyloid around the dendritic portions of the axons and extending up into the shafts and frequently up into the bodies, when eventually kills the neuron. There's been a lot of controversy around the fact that if you look at the center of these plaques, you can oftentimes find particles of aluminum in them. And there was a series of studies that showed that potentially aluminum, particularly in antiperspirants and deodorants, may have a contribution to the development of plaques. And the science behind that is incomplete, but what it looks like is that the aluminum is not a source of the plaque, but it's a reaction to developing the inflammatory reaction around the plaque, and is a healing response to the plaque and not etiology of the plaque. So when we look at the brain, here's a normal brain on your left, there's an Alzheimer's brain on the right, and you can see overall that the volume of the brain is diminished. The ventricles are larger on the Alzheimer's brain. The gyri and sulci are more prominent and deeper. And you can see that the area of the hippocampus and amygdala, the area where memory and the area of the temporal lobe are significantly diminished when compared to the normal brain. And that's the first area of the brain that's affected by Alzheimer's disease. So the hippocampus, followed by the temporal lobe, subsequently the insular cortex, which is the inside part of the Sylvian fissure here. And then clinically goes up cerebrally to the cortical surfaces of the brain, finally dealing with the functional portions of the brain and the brain stem. So is there anything we can do for Alzheimer's disease? Well, there are some imaging tests we can do in order to predict the progression of Alzheimer's disease. If we do SPECT imaging, which mirrors blood flow of the brain, we can see that the normal brain, the areas that I showed you on that cut section of the brain, enhanced with vascular flow, and the Alzheimer's brain has demonstrated clearly decreased blood flow to those areas of the brain. So what does that imply? It implies that, well, potentially, if we increase blood flow to the brain, could we reverse the ravages of Alzheimer's disease, or could we prevent Alzheimer's disease in general? And the answer to that question is absolutely yes. And the most powerful treatment for Alzheimer's disease or early dementia, or prevention of Alzheimer's disease, is cardiovascular exercise. So if you increase the blood flow to the brain, it decreases the incidence of Alzheimer's disease and decreases the progression of Alzheimer's disease in patients who already have dementia. Other things that you can do in order to prevent the progression of Alzheimer's disease are exercise the brain itself. And that's done through lifelong learning. People have done crossword puzzles, and people have engaged online forums for enhancing brain activity, as well as social engagement. Involving yourself in social interactions and doing service in the community. Avoiding smoking decreases the incidence of Alzheimer's disease, as well as treating the chronic diseases that reduce blood flow to the brain, such as hypertension, diabetes, and obesity. Other things that also enhance the brain health are plant-based diet. We know that as Ayurvedic clinicians. Turmeric has been shown to decrease the ravages of Alzheimer's disease to some extent, although some of the recent reports are really controversial around the turmeric use. And the volume of turmeric you need to take is between 11 and 22 grams per day, which is really high dose of turmeric, which is equivalent to about 2 tablespoons of turmeric every day. There's been also reports of the use of vitamin E in treatment of Alzheimer's disease and prevention of Alzheimer's disease with mixed results, and use of omega-3 fatty acids. Now, if you remember when we were talking last week about the brain is essentially 70% fat. Most of that is cholesterol. So if you increase the quality of the fats that go into the brain, you can potentially reverse the ravages of Alzheimer's disease and the issues around Alzheimer's disease. So what I'd like to do is just go over one of the tools that you might want to use, to kind of assess patients, for cognitive deficit. And I refer to, the mini cognitive examination. And the mini cognitive examination has 12 questions that they generally ask patients. And the first question is orientation to time. And so you want to assess, does the patient know what day it is, what month it is, what year it is, what day of the week it is, and what season it is? So there's 5 questions for the orientation to time: date, month, year, day of the week, and season. And each one of those gets 1 point. So orientation to time, date, month, year, day of the week, and season. Orientation to place. So the room they're in, do they recognize the room they're in? Are they in the hospital room? Are they in their bedroom? Are they in the living room when you're interviewing them? Are they in your office? What city they're in, what state they're in, and what country they're in. So there are 4 questions for orientation to place: room, city, state, and country. Immediate recall. So you'll give them 3 things to remember. And the one that's commonly used is ball, flag, and tree. So 3 things that are completely unrelated: ball, flag, and tree. And you ask them, can you remember them right now? And they get a point for every one that they remember. Attention. So you have them count back from 100 by 7. So it's 193, et cetera, et cetera. And for every 7th step they count back, they get a point. Spelling. Can they spell words backwards? And the word that we generally use for psychiatric evaluation is world. So W-O-R-L-D. So world spelled backwards is D-L-R-O-W. And so for every letter they get correct in order, they get a point. The next step is delayed recall. You ask them, do you remember those 3 words that I asked you a few minutes ago? Ball, you don't repeat it. You ask them those 3 words. And if they remember ball, flag, tree, they get 3 points. But for every word they remember, they get a point. So you ask them to name a common object. So you'll show them something like a pencil or your watch, and you'll say, do you know what this is called? So if they can recall what that is called, that gets them a point. So watch and pencil, it's common objects that they would easily recognize. You wouldn't show them something strange, that they would not ordinarily recognize. So you give them a 3-stage command and see if they can follow it. And the one that's commonly done is you give them a piece of paper and you ask them to take the paper. So if they take the paper, that's 1 point. You ask them to fold the paper in half. That's another point. And then you ask them to place it on the floor. So they take the paper, they fold it in half, and they place it on the floor. And you give them each of those commands once. And if they can follow each one of those commands, they get a point for each one. Okay, you write down on a piece of paper, you have it prepared, close your eyes, those words, and they're supposed to read it out loud. Frequently, Alzheimer's patients might read it and they just close their eyes, they don't read the words, but what you want them to do is read the words, close your eyes, and not perform the action. For each word they can read, they get a point. Next one is, you ask them to write a sentence. And the sentence must contain a noun and a verb. So you tell them, I'd like you to write a sentence with a noun and a verb. So they can write, Jane went to school, or whatever they write, as long as it contains a noun and a verb. And if it contains a noun and a verb, they get a point for each noun and verb. So they get 2 points. And then you draw 2 intersecting shapes. Usually it's a circle and a triangle, or a circle and a square, and they intersect. And you ask them to copy that. And if they can do it correctly, they get a point. You add up all those, and it's 30, approximately 30. And if they score 15 or below, it's very likely that they have dementia, and they need to be seen and assessed. And we can take them to the next step. So I just want to quickly look at a couple of cases. When we image patients who present with dementia, we want to be sure that they don't have something else that's causing dementia. And here's a brain on an MRI patient of someone who has hypertension. You can see the arrows pointing to these white areas in the brain. And this is a patient who had hypertension, who had little tiny micro strokes throughout the brain, presenting as dementia. So managing their clinical syndrome of hypertension would potentially improve their dementia. Here was a similar patient, but with more extensive white areas of the brain, resulting in a pattern of dementia. Here's a patient who presented with dementia. And if you remember from one of our first lectures, in the center of the brain, there was a pentagon-shaped structure known as the Circle of Willis, which distributed the blood supply to the brain. What you don't see on this patient is you don't see the normal blood flow to the brain. What you see is these just side branch vessels coming off of the main blood vessels. And this is a syndrome that's known as moya disease, which is relatively common in Asian Americans, and is a result of inflammation of the major blood vessels in the center of the brain, and they present with dementia. And it's treated with bypass surgery of one of the arteries from the outside of the brain to the inside of the brain, and reverses the dementia. This is central pontine myelinolysis, and you can see here on the MRI there's a bright area in the pons of the brain, and this is a result of disordered sodium metabolism. And patients who are living on their own, who have really poor nutrition, may not get enough salt in their diet, and they result in poor control of their metabolites, and they develop these plaques in their pons and present as dementia patients. If they're treated with slow resolution of this abnormal sodium balance, they become completely normal. If it's not resolved, they will die. And this is something that imaging of the brain is really useful to assess. And central pontine myelinolysis is a reversible disease where people present exactly like Alzheimer's patients and need to have imaging. Hydrocephalus is another syndrome where treating patients can reverse Alzheimer's symptoms. So you can see here in these MRIs and CAT scans, these ventricles are large and dilated, and draining these ventricles will reverse the Alzheimer's symptoms. So the question oftentimes arises, is there a crossover between Alzheimer's disease and Parkinson's disease? And the answer is cognitively, yes. Early Parkinson's patients can present like Alzheimer's disease, but the pathology is vast. So what I'd like to do is then move over to case number 29, which is a 63-year-old male who comes to your office with a several-month history of difficulty with his gait, and he has problems with his coordination. He finds walking difficult and has fallen on many occasions, especially when trying to change directions. He's also found that using his hands is difficult, and other people have noticed that his hands shake. And when you examine him, he has a resting tremor in his hands that disappears when he moves. So the typical resting tremor is a rotation or a rubbing of the fingers together, which is known as a pill rolling tremor. So it's either rapid twisting or a pill rolling tremor. It's also associated with rigidity, particularly in the arms, and you can barely get these people to move their arms. And as you move them, they snap back. They have this kind of snap back response to motion in their extremities, particularly their upper extremities, and has a tendency to fall backwards. And they have a very typical walking pattern. This patient did too. It's known as a festinating gait. They take tiny little shuffling steps until they get moving, and then they start to accelerate really, really fast until they almost fall over. And that's very typical of Parkinson's syndrome. Now, Parkinson's disease and Parkinson's syndrome are two different entities. Parkinson's disease is a disease of the brainstem where we've lost your dopamine concentration that allows for reduction of the amount of spasticity in the body. Parkinsonism or Parkinson's syndrome is someone who looks like they're behaving like they have the typical Parkinson's disease, but they don't have loss of the dopamine in their brainstem. So they have something else that's causing something that looks like the Parkinson's disease. And Parkinson's has been, recorded for millennia. There are Egyptian papyruses that mention it, and there are biblical mentions of it, and and it's found throughout the Ayurvedic texts. Diseases that call to this shaking kind of tremor that disappears with intentional movement. But the Parkinson's disease that we frequently see, results from loss of dopamine production in the substantia nigra, the part of the brainstem that produces, dopamine, the largest amount of dopamine in the brain. You can see here, adjacent to the hippocampus is the area of the brainstem known as the substantia nigra, and these cells shrink and they lose their capacity to produce more dopamine, which is why some patients have some partial response to replacing the dopamine. These people have a progression from, the motor symptoms, the tremulousness, the shaking, the pill rolling, tremor, the slowness of motion, the walking, the rigidity, to neuropsychiatric disease. They begin to lose their executive function. They have memory loss. They start to look like dementia patients. And this is where they start to cross over, between Alzheimer's disease. They lose executive functions, including planning, decision-making, and controlling their emotions. These people become extremely labile. They can be incredibly angry. They can become incredibly sad, oftentimes suffer from depression. The etiology of Parkinson's disease is approximately 15% have a first-degree relative with the disease. And so it runs in families, but the genetic transference has not been really well established, and so, is it nature or is it nurture? And there's a lot of evidence that shows that Parkinson's is also related to a repeated head trauma. So incidence of Parkinson's disease is seen in football players with blunt head trauma, as well as one of the most famous cases is, Muhammad Ali, with his Parkinsonism and potentially Parkinson's disease was likely related to repeated head trauma. There's also increased incidence in patients who have been exposed to certain pesticides and chemical agents. Agent Orange, Xyram, the pesticides paraquat and rotenone, and seeing those in the environment, we can maybe explain why we see clusters of certain patients with Parkinson's disease. But one of the interesting caveats is that people who smoke have a lower incidence of Parkinson's disease than the average population. And people who drink large amounts of coffee or tea also have decreased incidence of Parkinson's disease. So it's, you're damned if you do, you're damned if you don't, I guess, particularly with smoking. The incidence is, worldwide, there's approximately 7 million people suffering from Parkinson's disease, which is, prevalence about 1% worldwide. About 103,000 annual deaths are ascribed to it. It's the second most common neurodegenerative disorder after Alzheimer's disease, and it's diagnosed primarily in men over 60 years old. And after you've been diagnosed, the life expectancy is between 7 to 14 years. Diagnosis is through history and physical examination. Do you have the tremor? Do you have the gait disturbance? Are you developing the neurocognitive symptoms? And you can consider doing upashaya, with levodopa. And if they show some response, then you've made your diagnosis. It does mimic stroke and tumors. And you need to have at least, 2 of the 4 criteria, the resting tremor, the rigidity, the postural instability, the falling forward, the falling backward, and, the slow movement, but with that kind of, cogwheel kind of extension flexion. There have been recent imaging tests known as DOPA scans, where they can measure the dopamine in the brain to demonstrate, loss of dopamine in the substantia nigra. And here's an MRI of the brain, and here we can see, the region of the brainstem, and it looks normal. The patient has Parkinson's disease. But here in a normal brain, you can see in patients with Parkinson's disease, there's significant, decrease in the area of the substantia nigra imaging for dopamine. And if you add dopamine, levodopa to them, you can see that it comes back almost to a normal appearance. So this kind of scan suggests Parkinson's disease because there's loss of dopamine in the substantia nigra. Unfortunately, only a small number of people show positive for these scans.
Yeah, baby.
A common, relatively common mimic of Parkinson's disease is a disease that's known as Wilson's disease. And Wilson's disease is a disease of copper deposition in the brain. And it deposits in the brain in the area of the basal ganglia and the internal capsule. And what's very typical about Wilson's disease is if you look at the iris of the patients, you can see this golden rim around it, and that's actually copper being deposited in their iris. So when you do your clinical examination, you have someone who's presenting with kind of a strange dementia syndrome. You don't know if it's Alzheimer's, you don't know if it's Parkinson's disease. Look at their eyes, which is part of our, Astavita Pradiksha, and you want to assess, do they have this arcus of copper, which is deposited in the margin of their iris, which is diagnostic of Wilson's disease. And we keep a copper cup next to our beds at night filled with water, and we drink it every morning because the energetics of copper are reported to be strongly positive for healing. But it raises the question, how much is enough? And if we start to get a little bit demented, if we're drinking too much copper, maybe we should stop and go to stainless steel. Ways to treat, Parkinson's disease is, is the primary treatment is L-DOPA. And you may see patients who are on L-DOPA, which is a dopamine analog. And there's an herb that's Mucuna pruriens, which is known as the velvet bean. Matt might know it, which has dopaminergic activity, and it's been shown with incredible promise in certain patients with Alzheimer's disease. And if you want to follow it up and Google it, it's Mucuna pruriens, pruriens. And I've read a couple of case reports on it, and dosages vary between patients until you achieve adequate control. But there's very little downside. There's very little side effect. How can we treat them from an Ayurvedic perspective? The key is, can we achieve balance by increasing serotonin? And a lot of talk in the Ayurvedic community is about improving bowel health to decrease the symptoms of Parkinson's disease. And there is significant anecdotal evidence that if we treat vata disturbances and increase the health of the colon, that some of the signs and symptoms of Parkinson's disease begin to improve. It doesn't cure it, but it manages the symptoms. As clinicians, if we're partnering with Western clinicians that are treating patients with Parkinson's disease, one of the assessments we want to do is keep the patient safe, because these patients have a very high risk of fall. So we want to have fall prevention, and we want to be sure that they get good and adequate nutrition and pain management. There are some clinicians who will suggest using surgery to try and stimulate the substantia nigra, and that has not been proved to be clinically appropriate at this point. In your emails, I also included a cover of the original article by James Parkinson, which was published in 1817 on the shaking hands, which I thought it was kind of cool. And the world map of the world incidence of Parkinson's disease, and you can see there are certain hotspots, of Parkinson's disease. Areas that are red are areas where the highest incidence of Parkinson's disease, intermediate, lower kind of amber colors are less, and yellow and gray or Parkinson's disease is relatively non-existent. So it raises the question, is there a significant genetic component, or is it related to environmental constraints, and I think the jury is still out on that. Another mimic of Parkinson's disease is Huntington's chorea. And Huntington's chorea, one of the most famous Huntington's patients is Arla Guthrie. And they present exactly the same way. But what we see on the MRIs is the area of the ventricles have an unusual shape, and the caudate nucleus, which controls motor function and regulation, is eroded. And it's important to differentiate this from the Parkinson's disease, because this has a very clear familial inheritance, and Woody Guthrie has, a less prevalent form of the disease, but it's clearly something that needs to be known if you want to counsel your patients in terms of, having children and work up the disease, because it's untreatable and incurable. It was originally described by Charlie Huntington, who was a clinician in Connecticut, and his grandson, Charlie Huntington III, started the PA program at the University of Connecticut, and is an old friend of mine. I want to move on to stroke and talk quickly about stroke, because I think that this is something we really can intervene and act to save people. Stroke is essentially a brain attack, and we have a lot of protocols in place to help people with heart attack. And we've recently initiated brain attack protocols that help people with strokes. So the next case is a 72-year-old man, this is case 33, who presents to you with acute onset of right-sided weakness, unilateral right-sided weakness. He was eating breakfast when he suddenly lost strength in his right side of his body, and he was unable to move his right arm and his right leg. He also noted a loss of sensation in the right arm and leg and difficulty speaking. His medical history is remarkable for high blood pressure, hypertension, high cholesterol, and recently diagnosed coronary artery disease. On examination, when he comes to see you, his blood pressure is 190 over 100 milligrams of mercury, which is hypertensive. And his neurological exam is notable for right facial droop and a dense right hemiparesis, means he cannot move the right side of his body. A CAT scan is normal and shows that there's no bleeding, which is the initial first test. So the patient comes to you and a red flag comes up, and, you know, what do you do? How do you assess them? And the acronym is acting fast because every minute counts. So you assess the face, you know, does the side of the face droop? So you ask the patient to smile, and the normal side, the lips, the corner of the mouth will raise, and the side that's paralyzed won't move. So you know that that patient has facial paralysis. Is one arm weak or numb? So ask the patient to raise both arms. Does one arm drift downward? So that's the side of the stroke. Is it consistent with the facial droop? Is the speech slurred? Ask the person to repeat a simple sentence. Is it repeated correctly? So ask them a simple sentence. So, my name is Gerard. Can you repeat that? No. So if they show any of these, you know, we need to get them to emergency care right away, because our window for treating stroke is approximately 6 hours before there's permanent loss of brain function as a result of loss of blood flow to the brain. CAT scans and MRIs are done as an initial test to exclude pathologies like this, and people can present with stroke, and this is an acute subdural hematoma. And if you remember the layers of the brain we talked about last week, this is blood that's accumulated between the dura and the arachnoid layer of the brain. So this is acute blood in the subdural space, and this can be drained and the patient can recover completely. This is a typical pattern of what looks like a stroke of the right middle cerebral artery. And remember, most of the blood flow to the brain comes from the anterior, the front circulation, and the largest blood vessel is the internal carotid artery, which feeds the middle cerebral artery. So most bland or ischemic strokes occur in this distribution. Most hemorrhagic strokes occur in this distribution here. So this is the imaging that's ordinarily done when the patient comes to the emergency room. Now we see the CAT scan to determine whether or not they've had blood in their brain, which would preclude them being treated with clot busting. If there's blood in the brain, you can't give them something that's going to allow them to continue to bleed. Then they receive contrast material, which will show where there's a potential area of salvage for the brain, and it'll also show the anatomy and then demonstrates that there's an area of blockage and where the blockage is. So at that point, anti-clot agents can be administered within the first 6 hours and, you know, restore that area of wedge infarct to function. So a brain attack does not necessarily have to be a permanent abnormality. It's reversible with proper treatment. So if there's no hemorrhage, you know, a brain attack is essentially loss of blood flow to the brain. And, you know, what causes it? Well, oftentimes it's the result of atherosclerosis of an artery going to the brain, blockage. So it's a channel disease. Its stratumsi are narrowed, which results in end organ or distal organ abnormality. Can you also see strokes as a result of arteries being too wide? Yes, you can. If the artery is too wide, then the blood flow decreases because the vessel is just too fat. and the flow is diminished, and the result of diminished flow is that the end organ does not get enough blood flow. If the artery were to perforate or bust open, then the blood flow would decrease to it. And that's very typical for aneurysms of the brain. If you remember the anatomy, the most common etiology is going to be from the atherosclerosis and blockage of the area of the brain. Typical presentation is patient becomes paralyzed partially or completely on one side of the brain, and the side of the brain affected is the opposite side of the paralysis because there's crossover of the fibers. So if patient, in our example, presented with right-sided paralysis, this is his scan, you can see that he has a left-sided, stroke pathology developing. Also, inability to speak, Broca's area and Wernicke's area on the left side of the brain, profoundly affect patients' ability to speak. So they present with aphasia, inability to talk, or inability to create the words and then physically have the words come out of their mouths. Do some patients present with stroke-like syndromes and actually don't have a stroke? And the answer to that is yes. So when patients present with a stroke, when you assess them, they are paralyzed, and, hypertonic, but they also are hyperreflexive. So if you did a reflex test on their arms or their knees, they would have a lot of reflex because there's no inhibition from the brain anymore. If they had a stroke in their spinal cord or they had Lou Gehrig's disease, they would be hyporeflexive. So you can differentiate between the area of the stroke by whether the patient is hypo or hyperreflexive or not. So when you're seeing patients, what are the risk factors for strokes? Well, men more commonly have strokes than women. High blood pressure is a common etiology. So as you're doing your clinical history, atherosclerosis. So if they come in and they say, yeah, I've had a stent put in my heart, if they've had atherosclerosis involving their heart arteries, there's very likely they have atherosclerosis involving their carotid arteries because the pathology is a systemic pathology. It just doesn't affect the heart. It affects all your arteries. Diabetes increases the risk of stroke, as does smoking. Significantly increased risk of stroke by almost 18%. Use of alcohol, hormone replacement therapy increases the risk of stroke, as does increasing age. So the older you are, the more likely you are to have a stroke. Okay, so the therapy is assessment and then restoration of flow. Okay. The last thing I wanted to cover was, maybe we can get rid of that guy, was sleep disturbances. And we have a little bit of time to talk about that because this is one of my favorite areas to talk about, and not to market myself, but there's an article coming out in the Ayurvedic Journal of Health in the fall 2016 journal. If you don't subscribe, I suggest you do, either the hard copy or online. A Western Ayurvedic perspective on how to treat insomnia, particularly chronic primary insomnia, which is a problem for a lot of people. So the next patient is Anna, and this is a 42-year-old woman who's referred to Sleep Disorder Center with a complaint of chronic severe insomnia, which affects her daytime functioning. She's a single mother of 3 teenage boys, and approximately 8 years ago, she experienced insomnia as a result of, exogenous sources. She was threatened with bankruptcy of her small business and had a lot of stress in her life. Her business recovered about a year later after a lot of hard work, but over the last 8 years, her insomnia has remained unchanged. She's taken Restoril, Ambien, and other benzodiazepines to help her sleep. In addition, she's taken antidepressants because it was a question of whether her sleep disorder was related to depression, Eleptro, Elavil, amitriptyline, Remeron, and they really have been unsuccessful to maintain, good quality sleep. Each of them, always show an initial benefit and are very useful in crisis situations, but none of them lasted more than a week or two for therapy. And, she was concerned with, the potential for abuse, with increasing dosages. Her social history, she kind of feels that she's kind of hanging on by her fingernails. Looking after her business of sons takes everything out of her. She's so tired that, she has no social life. She really loves fly fishing, and she doesn't go fly fishing anymore and rarely goes to the gym, although she used to be a gym rat. And she feels kind of depleted, stressed out. She just drinks lots of coffee to stay awake, maybe 4 or 5 cups of coffee a day, just to function. And she finds herself falling asleep at her desk, and occasionally she'll catch a nap in the afternoon. When we did a 2-week sleep journal, she tries to go to bed around 11. She falls asleep, in less than 15 minutes, but occasionally it seems to take hours to fall asleep. So she has kind of a mixed pattern of sleep initiation. She wakes up 3 or 4 times per night, and at least one of these times she's up 2 or 3 hours, kind of staring at the clock, wondering when she's going to fall asleep again. And she usually gets out of bed and begins to work on the computer or watches television. And almost always she'll start to get sleepy just before she's supposed to wake up and go to work, and then she'll fall into a very deep sleep and not awaken until 7 or 8 o'clock, and then have to rush around to kind of get things done, get the kids ready for school, get ready for work. She's healthy on physical examination, but, she gives you, kind of the demeanor of lacking energy, and when you talk to her about her psychiatric history, she talks about, she has a lot of stress in her life. She doesn't seem particularly depressed or particularly anxious. And, she was subsequently referred to a sleep center, just to exclude other problems related to sleep that may be the source of her sleeplessness, such as restless leg syndrome, sleep apnea syndrome. And that came back negative. And her current lifestyle, she has situational distress, and doesn't cope well. Instead of, working through creating a ritual, she's managing, by, using coffee to stay awake. So, when we chatted, we talked about, decreasing caffeine intake, avoiding sleeping late in the morning at all costs, getting up, hide the clock to avoid checking the time, do reading rather than looking at the computer. And these didn't help. So we enrolled her in, cognitive behavioral therapy meditation course, which has showed significant improvement in her sleep patterns. So her strategies weren't working. Talking about sleep disorders is one of my favorite topics because the ancient scriptures really talk a lot about them. And Charaka says, when the mind, including the sensory and motor organs, is exhausted and they dissociate themselves from the objects, then the individual sleeps. That's from Charaka 21:25 Sutrasthana. And he goes on to say, though, that, some people are insomniac by nature, that they cannot dissociate themselves from their objects. Their chitta vritti cannot be dissociated. And therapy, as explained in Ashtanga, says we need to resort to things which are comforting to the mind. You know, sleep disorders are a real major problem. You know, road accidents are more commonly related to sleep disorders than they are to drunk driving. You know, and you know, the Exxon Valdez, in Prince Edward Sound in Alaska was related to inadequate sleep. And there are some reports after NTSB got done with the Challenger disaster said that, you know, the checklists that went through were not adequately evaluated because of the technician did not have adequate sleep. So, you know, sleep disorders, you know, are really an important, significant pathology that we really need to address. And, you know, when I'm seeing Ayurvedic patients for the first time, and I want to get the best bang for the buck, one of the first things I recommend is that they create ritual around sleep-wake cycles, because once they start to feel better about their sleep-wake cycles, particularly if that's an issue, then everything else becomes easy to treat after that, you know. Sleep and wake is complicated. Is it, you know, regulated and managed through the reptilian brain? And is it regulated and managed through the endocrine system? And the answer to that is it's regulated and managed through both. You know, there are certain cycles that we can see that, you know, manage sleep up and down. And, you know, some of it's related to light and some of it's related to cortisol stimulation. And what I'd like to do is just kind of hold up this drawing, if you guys can see it. Can you see it? Yeah, maybe. And the downslope of the curve as it comes around is related to, you know, the initiation of sleep, and the upslope of the curve as it comes up is the initiation of wakefulness. And at some points, the curves cross. So at some point, wakefulness predominates and sleeplessness is suppressed. And the opposite end of the cycle, sleep predominates and wakefulness is suppressed. And that's mediated through not only the hypothalamic, you know, and pituitary axis, but also the reticular activating system in the brainstem. And both have a significant component. The other thing that's significantly important is that sleep may be partly mediated through the pineal gland through the elaboration of melatonin. And the pineal gland is stimulated by blue light. So 440 nanohertz light is what stimulates the pineal gland to think that you should be awake. And for most computers, you know, iPad devices and iPhones, that's the exact wavelength of light that comes off of it. And since that science has been made known, you can get an application to download onto your computer which changes your background light to orange. I don't know the exact name of it. You can query it, but it may help if you really need to work late at night. You don't want the blue light background shining on your eyes, but orange light will not be as stimulating to keep you awake. Sleep essentially goes through two different cycles, the non-REM cycle and the REM cycle. So REM stands for rapid eye movement. And, you know, the non-REM cycle is 4 different cycles, and the non-REM precedes the REM. And each one of the cycles go through each one of their cycles in numerical order. So stage 1 precedes stage 2, precedes stage 3, precedes stage 4. And stage 2 is the longest of the cycles, when 45 to 55% of sleep is spent in stage 2 of non-REM sleep. And it's important in that area because that's not easily interrupted. So you can actually get good quality sleep if you stay in stage 2. And REM sleep is characterized by, mixed brain activity, bursts of rapid eye movement, relaxation of muscles, and this prolonged as you get towards your wake cycle, because this is the end of your sleep cycle, and it's also the most restful of your sleep cycles. What happens during the REM cycle? Your sympathetic tone is decreased, your respiratory cycle is decreased, your cough response is decreased, your growth hormone is increased, and your melatonin is slowly decreased over that period of time. Are there problems and changes of sleep with aging? Yeah, well, newborns and infants, require 16 to 8 hours of sleep per day, which kind of is what I need now. But circadian rhythms start to kind of evolve into the system at age 2 to 3 months. And over aging, up to approximately 25 years, the need for sleep decreases by approximately 1 to 2 hours, per year. And average sleep around puberty is between 9 and 10 hours per night. And at that point, REM sleep starts to decrease. As we get elderly, we require 36% less sleep than children. And, the ability to sleep decreases with age, but the need for sleep doesn't change. You need just as much sleep, but elder patients, have a greater difficulty sleeping. And that's a complex issue. And the most common etiology is depression. So as you're querying your older patients, and if they're talking about sleep abnormalities, it'd be important to kind of go down the rabbit hole of talking about how do they feel, what is their life like, and kind of peel away the onion of depression, because oftentimes the etiology of sleep disorders in elderly patients is the result of depression and loneliness. Oftentimes also they have comorbid conditions, such as, weight, obese, and have sleep apnea. They have inconsistent cues to light exposure, particularly if they're hospitalized. If someone is in an ICU that has no windows, they don't know if it's day or night, and it's hard to figure out, whether they should be sleeping or they should be awake. Irregular meal times, and decreased mobility, which leads to decreased exercise, decreased melatonin levels due to decreased function of the pineal glands. The pathophysiology, is complicated, but in Western medicine, we really don't understand the etiology of sleep disorders. In Ayurveda is really clearly well understood and diagnosed. There are doshic imbalances that result in sleep disorders for each of the doshas. Vata dosha presents as sleep abnormalities of inability to maintain sleep, so frequent waking up during the night. Pitta dosha imbalances present as inabilities to initiate sleep, but ability to maintain it. Kapha dosha sleep abnormalities frequently as a result of early awakening, termination of sleep. And all three present with being fatigued. So if you can assess, the pattern of sleep abnormality, either initiation, maintenance, or early termination, you can really pin down the doshic abnormality and treat insomnia by balancing the dosha. My favorite thing to do is have them keep a sleep journal, and in the sleep journal, you want to have them write what is their ritual around to preceding sleep. And if they wake up, when do they wake up during the sleep? And, how they feel the next day, so it's initiation, pathology in the mid portion, and then in waking up. Imaging is only useful to exclude other abnormalities that may be causing, sleep disorders, such as brain tumors or stroke or other things. And the lab tests or sleep studies are done to exclude restless leg syndrome and sleep apnea. Insomnia is diagnosed as either being primary or secondary. Primary insomnia is idiopathic, we don't know what's causing it, and it's either acute or chronic, so it lasts less than a month or more than a month. Secondary insomnia is secondary to some other pathology going on in the person, such as, other clinical process or psychiatric process or medication, or, dietary abnormality. And so those can be addressed and treated. So as far as working up the patient with sleep disorders, we want to know, is it a primary or is it a secondary abnormality? And if it's a secondary abnormality, treat the common etiology factor and the sleep disorder will resolve itself. If it is a primary sleep abnormality, and if it's acute and doesn't last more than a month and goes away by itself, you're done. But if it's chronic primary insomnia, it's a real problem to treat. And the therapy is to minimize the hyperarousal state, because the etiology of chronic primary insomnia, which affects between 6 and 8% of the American population, is chronic hyperarousal state. And the way to treat it is first create sleep ritual, sleep hygiene, stimulus control, decrease caffeine intake, stimulant intake, decrease light entry into the bedroom, create ritual around bedtime. Lifestyle and dietary changes, yoga and pranayama per dosha. What is the doshic imbalance? Is it pitta initiation? Is it vata maintenance? Is it kapha early awakening? Balance the dosha, according to yoga and pranayama. And a really elegant study was done in India several years ago, which shows that yoga and pranayama is the single best treatment for sleep disorders that are chronic and primary. Meditation, particularly mindfulness-based stress reduction meditations, doing a body scan, a yoga nidra type of meditation, massage using relaxing oils, or essential oils, marma therapy, and acupressure, particularly in areas that cause relaxation and not stimulation, counterclockwise rotation at marma points, using certain teas, chamomile, and Dr. Lott suggests using warm tomato juice and cherry juice and cherries, and physically positioning yourself on the right side, which seems to increase, relaxation. The only herbals that have really shown to have, significant improvement in sleep-wake cycles, are prolonged release melatonin, PR melatonin or melatonin SR, valerian and kava, L-tryptophan, St. John's wort, passion flower, ashwagandha, and others in the peer-reviewed literature have significantly mixed results. There are a handful of reports that indicate that Shirodara has helped, with sleep, but those are only anecdotal. So, sleep disorders, one of my favorite areas to talk about, are a primary problem in American culture, and I think we can assess patients in a really good quality way and treat them based on the etiology of disease. And this is where Ayurveda really trumps Western medicine, for treating patients with significant pathology. So at that point, I'm going to open it up to chat and see if you guys have any questions. Okay, did you say plaque is a protein? Okay, plaque is an inflammatory response to an abnormal protein being deposited in the brain, and the protein that's deposited is something that's called amyloid, and I'm writing it in. And that's the protein that's been observed to be in the brain. So the VPK sleep imbalances. So for Vata, it's waking during night. Pitta, it's initiation. And Kapha, it's early waking. Yes, I can. It's Charaka Sutrasthana 21, 25. And in the Varanasi one, it's page 381. And the Ashtanga reference is 766 to 68. You're welcome. Use dementia eyes sometimes interchangeably. Is there a difference in the plaque? Well, dementia is a clinical diagnosis, and Alzheimer's is a disease where plaque is usually observed only post-mortem. So Alzheimer's patients have dementia, but all dementia patients don't necessarily have Alzheimer's disease. So dementia can be seen in patients who have low sodium levels, but they don't have Alzheimer's disease. Or dementia can be seen in patients who've had, multiple strokes, but they don't have Alzheimer's disease. So dementia patients don't necessarily have plaque unless they have Alzheimer's disease. Make sense? Yes, plaque is only in Alzheimer's disease. You're welcome. That's a really good question. One of the things that comes up when we discuss it in an Ayurvedic forum is amyloid the AMA equivalent in the brain? And you might consider it is AMA of the brain, and it's undigested protein. But amyloid does occur other places in the body where doesn't take that form. But for this forum, yeah, it could be considered AMA of the brain. Yeah, both alcohol and pot, their function in the areas of the brain that control memory is that they prevent laying down of new memory because they decrease the blood flow and they cause inflammatory change in those areas of the hippocampus. They don't do anything for long-term memory, but they prevent the laying down of new memory. Alcohol is particularly true for that. You probably have patients who talked about having blackouts and don't remember anything. So alcohol, prevents the laying down of new memory. Pot acts in a similar way, but the dose has to be high enough. So usually you see it in patients who you do edibles. I'm not sure I understand the question, Ellen. Oh, okay. Well, I mean, when we're working at patients from an Ayurvedic perspective, we go through our 8-step process of, assessing disease and, removing the immediate cause of disease. So if a patient is smoking pot regularly, one of the things I would do first was, if that's obviously causing, or the etiology of causing disease, is work with them to replace that behavior with a behavior that will satisfy their need for smoking pot. Because, if you ask someone to stop smoking pot and they're a regular pot smoker, they're just not going to do it, and so we need to have a conversation with that person and partner with them in replacing it with a behavior that would give them satisfy the same need for them, to replace the pot smoking. Mm-hmm. Right. So, people can achieve the same type of meditative calmness, by doing good quality meditation and pranayama. And so working with that person, to do behavioral modification. Mm-hmm. It sounds like it was complex, and so I would look at his lifestyle and see what you could change in his lifestyle, and make small incremental changes so that he's compliant. Well, hopefully he's happy doing that. Could hearing loss be an early sign of future disease? The answer to that question is it depends. Peeling back the onion and kind of assessing the etiology of hearing loss, it could be complicated, and so I would go through, kind of a laundry list of things that are the source of hearing loss. Is it related to, trauma? Is it related to tumor? Is it related to medication? Is it related, to be sure that it's not something that's causing it? And then if its etiology is idiopathic and you don't know what's causing it, yes, it could be a sign of, disease involving Majada too, and it might involve other neurological symptoms and signs, and I would address that, as treating Vata and Maja, and work it from there. But first, I would be sure it's not something else that was organic that could easily be treated, such as someone on a medication that causes hearing loss. One of the common etiologies of hearing loss is certain antibiotics. Aminoglycoside antibiotics are typical for causing hearing loss. And so, getting a good history on the patient is a good idea. Is it also time to wake up? Well, the difference between the three, and there frequently is overlap, is that Pittas have a hard time falling asleep. They'll tell you they lay in bed and keep looking up at the clock. Vatas fall asleep right away, and then they wake up during the night a few times. And then Kaphas fall asleep right away, sleep the whole night, but wake up at 4 or 5 o'clock in the morning, close to Kapha time, and feel unrested, the next day. Kaphas may have a full night's sleep. And then they still feel tired the next day. Oh, hi, Pamela. So I wasn't planning on doing a webinar next week because it'd be in the middle of our Foundations 1. But if anyone would like special topics or topics that weren't covered to be addressed, let me know so that we can look at them. It is said that most people die past at night and mid-morning. The reason for that is not neurologic. It's usually cardiovascular, and it's a result of spiking cortisol levels and heart attack. Most people, that happens with them. Yeah. So does anyone have any more questions? Thank you. If not, I will see you guys in a few weeks up in Massachusetts. And we'll be looking at musculoskeletal diseases. And have a great night. See you soon.
Good night, all.
Yes, give me a call.
Yes, I will.
Okay.
Yeah, don't work too hard.
Yeah, I won't.
Good night, everybody. Thank you.
Blessings to everyone. Thank you.
Thank you. Good night.
Good night.